אז ערב טוב לכולם. ההרצאה הזאת היא חלק מקורסי הבחירה של התוכנית הישראלית לפסיכותרפיה בין אישית. ובחודשים הקרובים, כמו שאתם יודעות, התקיימו הרצאות בנושאים שונים, כולל IPT בטיפול בהפרעות אכילה, במניעת אובדנות, קשיי למידה, קשב וריכוז, וטיפול בתקופת ההיריון והלידה. וההרצאה הזו על טיפול בטראומה הוקדמה כדי לאפשר לכל המטפלים חשיפה לכלי עוצמתי ומבוסס מחקר, שמאפשר טיפול בטראומה בלי חשיפות, מה שיכול לעזור להרבה מטופלים שלא מעוניינים בחשיפות, שחוששים מחשיפות, וגם למטפלים שביניכם שלא מטפלים ב-PE או CBT או בכל אחד מהכלים האחרים שכוללים חשיפות. את ההרצאה מעבירה אלכסנדרה קליין רפאלי, מנהלת השירות הפסיכולוגי באוניברסיטת בן גוריון ומתאמת הכשרות בהתמחות הקלינית של השירות, שותפה בהכשרת מטפלי IPT במדינות מתפתחות דרך פרויקט משותף של אוניברסיטת קולומביה וארגון הבריאות העולמי, ויושבת בוועדת ההסמכה של הארגון הבינלאומי ISIPT. Alexandra, thank you very much for joining us, and I would love to hear how you were involved in a research project with John about IPT for PTSD. So if you could start by giving us like a few words about that, and then we would love to hear your presentation.
I'd be happy to. That's actually a really nice way to start. Let me just first really thank you, Sharon, and I'm just really proud to be part of this school, something I know that had been in discussion for so many years, and especially in times like this, for you to get this off the ground and moving forward is no easy feat, and we're all really grateful for that. There was some recent learning from John Markowitz. I see it not here. I think there was a webinar, I hope a recording maybe that went around after. So you can certainly, hopefully learn from that too and really hear more about the research. I won't talk as much about the research, but to answer your question, I first learned IPT sort of by chance when I was a graduate student, and I fought my way in as a practicum student to learn IPT at Columbia University, first with Lady Verdelli, then with Laura Muffson, and I was actually referred to John Markowitz when he was interviewing people to be therapists on his IPT for PTSD study. He had just gotten an NIMH grant to study for 5 years the treatment that he had started piloting, but wanted to compare to other treatments like prolonged exposure with that hypothesis question of is exposure really necessary, and relaxation exercises. So I just met him after knowing some IPT, but not knowing him well, and just being brought in to be a therapist on his study. I'm going to talk tonight about a case study from that practice that I'll then distribute. I'll give to you. You can give out to everyone to read. We can give it as homework maybe even for next time when we do more of the practical. So that was the very beginning of his study, which was shortly after 9/11. There have been a lot of comparisons to what we're surviving, living through in 9/11. I think there's some to compare to, not a lot. But since then, after moving to Israel, I stayed in touch with him. We published together. I brought a lot of his work to Israel and did a lot of trainings and workshops. And over time, we've continued to stay in touch, to write together, to present together. So to learn from him is a gift, and I hope you all have that chance. I think even on our IPT website, we have some recording from the workshop he gave years back. But I'll give you highlights of his study and his approach to using IPT for PTSD. So that's how I got to meet him, and that was over 20 years ago.
Thank you.
Yeah, so I'll share my slides now.
Yeah.
Okay. You can see those okay? Wait, hang on a second. There we go. Yeah?
Yeah.
Okay. So here we go. here's an overview. Now, if I understand, we have 2 days together. We have tonight for an hour and a half, correct? And then we have next week. So tonight, I'm going to do a lot of talking. Next week, hopefully we all will do a lot of doing. I think it's important to introduce the approach. First, a quick review of IPT. As I heard from Sharon, some in the group here are learning IPT for the first time. Familiar faces, I know it well. Just a really quick review to kind of understand the rationale behind applying IPT for PTSD. I'll then give you, with the time we have tonight, a little bit of the phases, the guidelines, the technique, and end with the beginning of a case example that I'll then distribute to everyone, and you can read more in depth. What I think I'd like to suggest to do, and Sharon, tell me if this works for you, is since most of tonight will be just slides and me talking, if there are questions, we can maybe stop the last 10 minutes or so for a couple questions. But then if there are more questions, maybe people can put them in the chat, Sharon, and we can collect them. And that way I can sort of prepare based on very specific questions for next week. If there are specific questions around current cases that are being seen, current patients, comparing to other treatments, it would help me to kind of know what's on people's minds so that we can tailor next week's experiential piece more to all of us here at the workshop. So next week, we'll really practice and do some role play, maybe a simulation, and save some time for everyone to really think about and reflect on this approach, ways in which you might like to use and apply it in the future. I'm really very happy to share my materials and share these slides. Everything I have is from all the teaching I've done over the years, more outside of the country than here. So they are in English, but I'm really perfectly happy to share these, have people use them, translate. We in our IPT community believe very strongly in disseminating, and that means we don't hold our materials too closely. We share and we distribute. So I'm happy to give these slides afterwards, and I hope people will already maybe be thinking how they might adapt them to their environment. Okay, so we have to, before we talk about post-traumatic stress disorder, and to think about where we are right now during this war in our lives, we're not post-trauma, we're living traumas. And I will talk specifically about post-traumatic stress disorder, but that's actually a very small population of the world who experience traumatic events. So we want to be thinking about individual PTSD versus collective trauma, because there's a big difference. With individual PTSD, there's the personal response to something horrific that we've experienced, we've been close to, and symptoms that surface, re-experiencing the event, avoiding the event, how it affects our mood, how it affects our behavior. Collective trauma is something different, and we have to be thinking about that, the societal impact from shared experiences. And that manifests in sort of not just shared grief, but cultural shifts. We all may feel the same way. Most people I'm talking to lately in my life are all talking about ways in which they feel what we're all living through is really changing us, not just as individuals, but as a group, as a culture. So we know a lot about intervention for PTSD. The psychotherapies, there is more than one, and many work. The ways in which we mobilize social support, that's something IPT spends a lot of effort working on. The collective trauma we know less about, but I would actually argue, I think if we think about the core components of IPT, there's a lot we can draw from in thinking about collective trauma as well. How we bring people together and working as a community, and how we help people start healing. So I'll talk mostly about IPT for PTSD, but I'll mention also the kind of global interventions that are being done where there's kind of a crossover between IPT, IPC, global initiatives from the World Health Organization, and the work with PTSD. So just take a minute and think about this phrase. I like to use this when I'm teaching IPT. And again, I know some of you are new to IPT, some of you are very experienced with IPT. When we're trying to distinguish this approach from others, there are commonalities, but when we're trying to distinguish this approach from others, I like to think of this saying. It's easier to act yourself into a new way of feeling than to feel yourself into a new way of acting. This is loosely based on Harry Stack Sullivan's work, who was a great theoretical influence for the original IPT intervention. And many behavioral psychologists believe this way. And I think especially when we're thinking about IPT for PTSD tonight, we want to think about this idea that there are those approaches that might focus on the emotions at the start, focusing on how one feels. We start very early on with experiential exercises, always keeping emotions in mind. Always. It might not be part of the acronym, but emotions are a huge part of IPT. But we get people doing very quickly, and we're working and helping them to motivate towards change. And the reason why we think about this, even maybe more so for IPT for PTSD, is we're going to look for a minute at the symptoms and think how much people avoid their feelings, how much people with PTSD numb anything that might closely relate to the experience they had that's too horrific to remember. So we have a hard job in IPT in trying to help someone with PTSD actually feel their feelings. And one way to do this that can ease them a little bit quicker into that is through experiential exercises, is through having them act first, feel next. So principles of IPT, this is a review for all adaptations. We believe that pathology is triggered by the interpersonal problem area or areas, and we focus on symptoms through the lens of interpersonal functioning. As Sharon mentioned earlier, what's unique to IPT for PTSD is that we're not thinking of the event as much as we're thinking about the important people in someone's lives and the way in which they're relating to those people. So we aim to reduce symptoms. It is a medical model approach. We think about symptoms first. We aim to reduce them by either mobilizing social support and or enhancing interpersonal functioning. These principles are no different for IPT than PTSD, again, than any other adaptation. Problem areas also are no different, although for John Markowitz's work with the studies that he's run, he's actually limited these problem areas to the first three. So you're familiar with these, grief being one problem area that you're assessing for in your interpersonal inventory. Grief, role transition, interpersonal dispute. The problem area that John Markowitz left out of his studies were interpersonal difficulties, sometimes called interpersonal deficit in the literature, or the general loneliness and isolation. The reason why is this is an area where we're not looking for a specific life event as much as someone who's been experiencing these ways of life or ways of being over time. So IPT for PTSD is looking at life events. An event has to have happened for one to be diagnosed with PTSD. And automatically there's sort of an innate role transition for anyone who's diagnosed with PTSD, because they'll often describe themselves as pre and post, their life before the traumatic event or their life after. And even if, and in the case of the case study that I'll share with you tonight, there are multiple traumatic events, there's often a one that stands out that's really signified that change of that's the person I was before, this is the person I am now. And often they see themselves as a healthier person before, unhealthy after. So if we're thinking of post-traumatic stress disorder, we're really thinking of either grief or role transition or dispute, not so much the loneliness, isolation, although that obviously may be something a person is experiencing, and there may even be comorbidity where that's even stronger. So when I teach IPT, I always say, if you remember nothing else of all the talking I've done, remember this slide. Keep this image in your mind, that what we're doing in IPT is always, always, always trying to help someone link between their interpersonal experience, their mood, their symptoms. You feel a certain way, what happened? What's happened? How does it make you feel? And again, even more important when we're thinking of post-traumatic stress disorder, when there's so much avoidance of the memories, the thoughts, the feelings around the traumatic event. We want to help them feel again. And it may not be from the traumatic experience as much as just throughout their life. So if you think just, during your day, moments of interpersonal experience and how it affected your mood, both positive or negative. I had a moment this morning when I think of highlights of my day. I was driving into Ben Gurion University at about 8 in the morning, and a lot of the gates are closed right now because of the situation. So you're waiting in a little bit of a line to enter through the gate. There's a little more security than usual. And just as I was entering, the car before me stopped at the gate, and the security guard kind of looked at the person in the car. And all I saw from behind in my car was the person in front of me hand a granola bar to the security guard. And I had this moment of warmth of what a wonderful experience of seeing this moment of sharing, seeing the smile on the face of the security guard. That impacted my mood. That's one of so many experiences we have throughout our day. With IPT in general, we're constantly trying to help make that link for people when they're not noticing, and especially with PTSD when they're not wanting to notice and doing everything possible to avoid. So biopsychosocial model, again, for IPT, the model itself isn't unique to IPT, but again, we're just kind of refreshing and keeping in our mind that as we're working with an individual and we're assessing all that we can know about the psychological factors, the social, the biological. In IPT, what makes the person unique is that interpersonal crisis. What's going on in their life here and now that's impacting their relationships? That's the psychological distress. That's what we want to work on. Not necessarily the event that happened maybe one month ago when they were at the Nova party, although that's important to know about. What's happening currently, here and now, disputes with others, pulling away from others. We want to hear where the distress is. That's the interpersonal crisis that we can work on in IPT, and no different for this adaptation. So you're going to learn lots about adaptations from Sharon's school. There are too many, obviously, for one slide. These two are the ones I'll keep referring back to. IPT for PTSD, as Sharon mentioned again, doesn't focus on exposure, which is not only surprising, but has been somewhat controversial in the literature. Why are we thinking about a non-exposure-based treatment when we know the strong effect exposure therapy has on individuals? And the other adaptation, because there's some crossover, is a manual that if you're not aware of, you should be, which is free and online. Because IPT was adopted by the World Health Organization, this group manual has now been translated, I think it's like 5 or 6 languages. We have an individual one as well, translated into Hebrew that I think Sharon probably has talked about. But there again, because the global initiatives of IPT have gone into a lot of war-torn countries, Uganda, Nepal, Ethiopia, there are things we can think about and learn from the way IPT has been used with non-mental health workers and on the front lines. But today we're talking about IPT for PTSD. And again, we're thinking about this kind of controversy around the approach. So just stop for a minute. This is, I know, a sort of colorful and loud slide. Let's try to kind of wrap our minds around this idea of post-traumatic stress disorder. And maybe even if you could, for a second, think for yourself or even write into the chat, when you think of post-traumatic stress disorder, what events come to your mind? What do you think would trigger this syndrome? You don't have to say them out loud. Just think about it, or if you want to write in the chat to share. We're flooded right now with horrific events of all kinds that we might not even yet be in the realm of post-traumatic stress disorder, which takes a good month or so to surface. But certainly I think we've all thought of or known or felt what almost might feel like acute stress disorder. I had the chance to look at the webinar that Sharon, I think, sent around, the unspeakable terror, the gender-based violence on October 7th. And I felt myself really having physical reactions just sitting through verbal descriptions of things that happened over a month ago now. So think for yourself of what constitutes a traumatic event. It's different for everyone. There's the capital T of trauma and the lowercase t. Traumatic events happen to all of us or affect us in different ways. We don't all develop the disorder, but I will talk tonight about what happens when you do. We can think about times of war. We can think about ways in which people have experienced abuse, whether it's verbal, whether it's physical, whether it's sexual. Back to the work that John Markowitz did, came out of the experiences many people shared after 9/11, again, after, not during. And he actually shared recently that they're still getting referrals to Colombia for people just now surfacing of symptoms from 9/11. So, that tells us that it sometimes takes a long time before people come to treatment when they've been suffering for several months, several years, decades sometimes. And B, that tells us that we can't always know how and when people will become post-traumatic. So this is a busy slide. And again, you'll get these slides and you can just as easily open the DSM-5 and read the criteria for PTSD. But a couple things to keep in mind that are important. And I think because of us all thinking, how are we going to help everyone around us during this horrific time that has no textbook to define or predict or help us through how we should work most or best. The criteria and the diagnosis for post-traumatic stress disorder has not been fixed in time. It's evolved. It evolved from DSM-4 to 5. Likely it will evolve still. And that's important to keep in mind because I don't think we want to be rigid in criteria or defining post-traumatic stress disorder as much as thinking how we can intervene and help if someone has a milder version or someone doesn't fully meet the criteria of PTSD. That doesn't mean we can't use the approaches we know well, or the alternative approach we're thinking of tonight. So importantly to think of this as a kind of work in progress, let's say. What's changed over time is more criteria, but added behavioral clusters. So thinking a little bit not just about the thoughts, the memories, the flashbacks, but the interpersonal piece, the behavior, the way one is in relationship with other. The other way was in relationship with themselves in terms of, let's say, self-destructive behavior. So you do have to have symptoms that meet each of these clusters, the intrusive symptoms, avoidance of traumatic stimuli, changes in your thoughts, changes in your mood, and some change somehow in your arousal or your reactivity. But it will be different for each person. And most importantly, for us to think about, and for the case example I'll give you tonight, think of someone who is haunted by the memories of an event that occurred or events, someone that is emotionally numb. They can't talk or think about the trauma. I even noticed this, Sharon, in that webinar. Towards the end, the presenters on the symposium were saying, I can't even think about it. I don't want to say more. I can't tell. It's very hard to verbalize the images that are coming up in our mind. So it would be even harder to allow ourselves to feel what we might have felt during those experiences. Thoughts and feelings become increasingly and persistently negative. Bleak thoughts about oneself and the future. Negative, disproportionate thoughts about the events themselves. And intense feelings. This is really important to think about. Intense feelings of fear, horror, anger, guilt. There's been a lot of discussion about guilt lately, shame. You can understand why one would cut off from these feelings. whether it's to the extreme example of dissociation or just numbing. And there is the kind of physical of just sort of always or often being on edge, not being able to concentrate, feeling irritable, not being able to sleep. I've been having startle responses lately. I don't know if you all have. This hypervigilance in relationships, with yourself, again, with others. So you can see how it would impact others around you as well, to the point where people sometimes really withdraw from being around others. With all of that said, with us thinking of what is PTSD, what are those traumatic events that occur in our lives, it is important to remember again that not everybody develops PTSD. So they say, almost all of us, almost 90% of the population have encountered a traumatic experience at some point in their lifetimes or will. And only a small percentage actually develop full PTSD. So this speaks really importantly, and I think we all need to give ourselves hope these days, to post-traumatic growth, to the idea of resilience, to the idea that we all witness, experience, think about, hear about horrible things, and we find ways to move on, to cope, to live through, to give to others, to love others. And with that in mind, those who do develop PTSD, it really is a debilitating condition. I think this is what I remember most strongly being part of the study that John Markowitz created, comparing PTSD, IBT for PTSD, to other approaches, was just how chronic of an illness it was for those turning to us, how long the condition had occurred, how sometimes many events had happened in their life, and how often there was comorbidity, not just PTSD, also depression, also substance abuse. So we're working with a population who often have these residual symptoms, kind of lingering effects, long after even the acute phase of the traumatic experience, which really cause a lot of challenges in their own lives, in their own functioning, and in their relationships. And individuals can delay treatment. As I mentioned earlier, just now, some people are coming for treatment for 9/11. There could be the reason of stigma, although I working with young adults, I find there's less and less of that, which is good news. There could be the minimization or avoidance of symptoms. Again, finding a way to sort of cope in your life without ever totally encountering the symptoms full on. And there could be a lot of mistrust in the helping community. And the case example that I'll share with you tonight, this was someone who'd been in several therapies that didn't really help before coming to us. So there's a mistrust that's part of the post-traumatic stress disorder, and then sometimes even a stronger mistrust with helpers. So we want to keep all of that in mind as clinicians if we're working with somebody who really does carry this diagnosis. So why IPT for PTSD when we have so many treatments that work? We know exposure works. We have CBT. If we look at the whole umbrella of different cognitive behavioral therapies, one thing in common often is some exposure component. We have prolonged exposure that we know of Edna Foa's. We have cognitive processing therapy of Restics. We have eye movement desensitization and reprocessing. I think again from Sharon that there was a webinar of EMDR and there was something like 600 participants. EMDR is powerful and effective. We also have virtual reality exposure therapy. When I first arrived to Israel, I was on a panel comparing IPT for PTSD to CBT, to CPT, to virtual reality exposure therapy, which was used a lot in the States with war veterans after Iraq, after Afghanistan. Very, very powerful. We all can think about our own lives and ways in which we avoid the things that are difficult. But if we can, even the littlest bit, approach that which we're avoiding, we're going to feel a little better. When I finally finished my taxes that I was avoiding for months, I felt a little bit better. Exposure works. And it works for the most traumatic of experiences too, to bring someone down to ground zero in New York City. If you can get them there, if they've been avoiding going there or thinking about it, will help. So if this approach helps so much. Why? So John Markowitz's hypothesis in trying to adapt IPT for PTSD was, what about the ones who won't go through this treatment? What if it isn't for everyone? What then? Can't we think about a range of evidence-based approaches and think about which one might fit one from the next? So we all can get prizes at the end, as they say in Alice in Wonderland. It's not just one approach, and it's not the best approach, but is exposure really necessary? So with that hypothesis in mind, he compared to prolonged exposure relaxation exercises. Since then, have been like 13 or 14 other studies, and it's shown to hold up on its own. It's shown to be really effective when there is comorbidity with depression, because one thing we certainly know about IPT is that it's extremely powerful and effective when working with pretty much any kind of depression. So is exposure really necessary for anyone to relieve their symptoms or reduce their symptoms of post-traumatic stress disorder? And the argument, I think, really grew in kind of looking at the literature and understanding from even therapists and patients' accounts of exposure-based therapy that it isn't for everyone. In fact, it can be very grueling for the patient if anyone has experienced it or gone through trainings and given exposure-based treatments. It can be really hard work. So patients refuse sometimes to even start, and there's a pretty high dropout rate. So if patients get through the protocol, they'll do well, but they may not. We also know that with any kind of anxiety symptoms can surge before they subside. That may be enough reason for someone to drop out. And secondary issues can actually go unnoticed if you're focusing so much on the traumatic event and not what else. And that, back to the study I'll share with you, the case study I'll share with you, is really important, because we don't want the person to feel that their PTSD is them, is their personality. We want them to understand they had a traumatic experience. It happened outside of them. It's not all of them. So secondary issues, if noticed, can sometimes be part of the healing as much of, or even more so, than the traumatic experience itself. And importantly, exposure-based therapy can sometimes be discouraging for the therapist. It takes a lot of time to train. The psychoeducation requires buy-in. If somebody has been approached in another, trained in another orientation, it may be hard for them to believe it works, and then it won't work. We have to buy in as therapists before we can have our patients buy in any way. And I think another way it can be discouraging for the therapist is when we think of exposure-based treatments, there's a lot of monitoring that is necessary. Symptom tracking, which involves some self-evaluation of the therapist. If the patient's not doing well, the therapist might feel they haven't done well. And that can sometimes really discourage the progress or the process of the therapy. So why IPT for PTSD? We can think about if exposure doesn't always work and isn't always necessary, then what could we use? So PTSD, as we've defined, is a life events disorder. A horrific event happens and the person's life changes profoundly. IPT mainly focuses on current life events. IPT offers this alternative theory and technique. Forget the exposure. Don't worry so much, or never mind so much about the traumatic experience. Not that we don't care about it. We want to hear about it. But we're really interested in the way in which somebody is functioning in their relationships, and the way in which, if they're not, how they're reaching out or getting support or giving support, which helps too. So IPT can really address this sense of isolation and detachment and really help and focus on emotions, the building of, the defining of, the feeling of emotions. So really we could say IPT for PTSD, or just IPT, it targets these symptoms: avoidance, restricted or dysregulated affect, feelings of anger, irritability, any discomfort with intimacy relationships, this interpersonal hypervigilance that can occur in PTSD where somebody really doesn't trust themselves, their environment, or others. So as John Markowitz likes to say, and I think it's a really important sentence that we return to again and again, is that emotions are powerful, but they're not dangerous. We want to help that person who's experienced a horrific event to feel their feelings. They may be intense, they may be hard, but you can have them. So in adapting IPT for PTSD, the phases are the same as the original manual of IPT, but in the initial phase, along with assessing for the doing that closest circle that you may have done already, assessing for their map of their interpersonal world, who are the important people in your lives and where would you place them and how connected are you to them. You also would assess for the trauma and get a timeline if there's been more than one traumatic event. Tell me about the traumatic experience or experiences. And at the same time, you're kind of assessing for emotion. How much are they able to connect their feelings to what they're saying? Because you're going to try to, over time, help build these sort of emotional signposts. Help them say, I feel angry, I feel scared, I feel sad. When often, when someone is describing the event, they might be very, very detached. And if they've described it many, many times, they may talk about it as something that happened almost to another person. So you're assessing along with this in this interpersonal inventory about the important people in their lives for the traumatic experience itself and just their emotional barometer, let's say. So by the time you've gotten to the middle phase, just like with any IPT approach, you've formulated enough to know what problem area you're working on, whether it's grief, whether it's life change, whether it's disputes. And then you are honing in on how have you been since we last met? What experiences have you had? How do they impact that problem area? But you're not discussing the trauma. Now, you don't want to stop someone and say, I don't want to hear about it, but you need to keep bringing them back to the here and now to address the emotional barometer, whether there's a numbness of their feeling, whether there's some interpersonal hypervigilance, whether they're very negative in the way they're thinking or acting, and how much avoidance they're doing, because they'll be doing some, if not a lot. So with whatever problem area is decided, with whichever techniques you're using, and you do use the standard techniques of decision analysis, communication analysis, role play, you're really trying to get them back to that person they were before the traumatic event through survivorship, finding their resilience, helping them grow, helping them see in this new role they can be themselves, maybe even better or stronger, helping them get back on track. Again, if they're carrying this diagnosis, there are ways likely they're not functioning socially, emotionally, academically, financially, professionally. So by termination, if exposures happen, they happen spontaneously. They start connecting more to others. They initiate going into a new volunteer experience. So you want to have assessed progress by how much you notice they're able to do that maybe they couldn't do before or were avoiding, but also how much they're able to feel. There's this wonderful song from the old musical, hip-hop musical, Hamilton, Teach Them How to Say Goodbye. Here you want to teach them how to feel the goodbye. They might be able to really feel the sadness in saying goodbye to you because it's a time-limited approach. And that would be a good thing. That would be something to praise them about, because likely they started in a very numb stance. If they can start feeling anything from even sadness to saying goodbye to you, that's something you would praise. So when I teach IPT, I often like to say, what makes this approach so accessible to therapists, no matter what their past training or orientation, is that it isn't so rigid in that you have to memorize formulas, memorize terms, memorize session to session. We like to say it's more of a manually guided approach than manually driven. But there are some do's and don'ts. And I think with IPT for PTSD, these are probably the highlights of do's and don'ts. You do want to really facilitate this reparative kind of world transition, that whether or not that's the problem area, they've most likely gone from feeling like they were a traumatized, unhealthy person, and you're trying to bring them back to the healthy person. That they were healthy before and they're currently feeling traumatized. There's this process of world transition. And you want to understand how the traumatic kind of shattered their relationships, their feelings that they used to probably have of joy, their ability to have some kind of routine. And you do always want to provide hope. There will be, even if not the diagnosis of depression carried along with PTSD, there will be a hopelessness. If someone has been experiencing these symptoms for a long time or has lost someone dear to them, can't remember back to the horrific events, you want to find ways to provide them hope. Sometimes we'll say in IPT, if you don't have the hope, I'll carry the hope for you. I'll help you feel that sense of hope again. So those are the things to do, and maybe the things that are highlighted in this approach specifically. What you don't want to do is engage in psychodynamic interventions that we all may know, appreciate, have experienced, done ourselves as therapists. We don't want to share dreams because we're working in the here and now. And we're not working so much on transference, although the relationship in the room is important. Our goal is to get the individual to trust and to feel comfortable with and to share with the authentic people in their lives, those people in the closeness circle. If they need us less and their circles more, we've done well. So they may come and share a dream. You, again, don't want to say, I don't want to hear about it, but you want to try to bring them back to the waking events. Maybe at most, how does that make you feel? Or how do you feel telling me about it now? Or how does it connect back to the problem area we're working on? How does it come back to some of those techniques that we did in our role play? You want to try to bring them back to the waking events. And John Markowitz actually discourages assigning homework, which we do sometimes in IPT. You could do some kind of practice. You might want to role play an exchange between two people and then say, give that a try, or do you think you could try that with the person at home and let me know how it goes next time? But his argument for not assigning homework specifically for this adaptation is that there is a sense of feeling very debilitated. There is lack of hope, and there often is lack of functioning in one's current daily life. So you don't want to set up too many chances for them to feel like failure, where with cognitive behavioral therapy, we almost hope for the chance that they might not do their homework because it allows for a real discussion about why not. Was it something about the assignment? What could we do differently? Connecting their thoughts and their feelings to the failing. But here you don't want to discourage them so much that they withdraw or remove from the therapy. And then finally, you're really not bringing back the traumatic reminders. They may bring it up. You're not going to shut them down or shut them off, but you want to kind of keep the focus on the interpersonal. Now I'm going to go through a case example. If you're thinking of questions, I think if I could take maybe one or two now, and then we'll hold off for any more at the end. Does anyone have a question just up until now about the approach itself?
I have a question.
Great.
Two things. While listening to you, because we're in a new world and in a new mental health world after October 7th, I'm curious about the combination of IPT for PTSD and IPT for depression and anxiety and, other stuff that we're going to see very highly comorbid. That's one question. And my other question is, and I hope John will never hear me ask this, but I have to. what if we do want to do exposures for some of the patients, not PE, not obsessive, but not wait for the exposures to come, but really combine CBT-based and IPT-based approach?
I don't think that's so dramatic or controversial, and I think you could dare ask him and he would talk about it. I mean, when we were doing the study...
Afraid of John.
Oh, okay. Wow. I encourage you, that'll be your exposure. You should ask him next time you see him. Knowing him as much as I do, I know for one, when we were doing the study, just like most people who are running studies, they're trying to keep an approach pure.
Right.
And so you know, when we were listening to tapes and we were just trying to make sure that people were really doing IPT, we had to try to make sure that they weren't doing exposure, because here we were comparing it to PE. So how do we...
Yeah, but real life, forget research, real life.
So real life, people often will bring things that are like an exposure, and you wouldn't want to stop them, but you would want to try to balance things. So here, I'll give you a case example. One of the patients from that study who I worked with was a young adult who had a terrible accident where he was intoxicated, fell into the train tracks in New York City, and had a really bad injury, but survived. So he had a disability. He wasn't able to walk well. He walked with a limp, and it took a long time to heal. And in the therapy itself, what was really more on his mind that was a problem was, how do I go on a date walking like this? And how do I continue the work I was doing where I needed to be functional and I needed to walk? And he also had to move back home to live with his mother because he wasn't able to make a living anymore. And the disputes and the conflict there were really, really upsetting. So his daily life functioning was not good, never mind the event. During the therapy, his family pushed him to sue what's it called? I already forgot. The Transit Authority or something, to sue the subway system of New York City. And in order to do that, he had to give a deposition, which in itself was an exposure. So he was having to prep for and tell the story. And it was an interesting part of the therapy, because where I was trying to focus on the interpersonal, the conflicts with the mom, the getting him back to just having a date and feeling okay with that, he was reliving the experience and having to talk about it. So there wasn't the don't talk about it, I don't want to hear it. And he was having some exposures of his own. It might not have been PE exactly, but he was forced to keep telling the story. So that obviously was part of his life. But the part of helping him become a functioning individual had a lot more to do with what we all know so well about IPT and what happens also in helping somebody with loneliness and isolation, connecting to others, sharing with others frustration, feeling okay with yourself. This traumatic event happened. So I don't know if that answers that. I think, with IPT especially, we don't want to feel that people have a lot of do's and don'ts on their slide. And I think if there's going to be some exposure and people are ready to tell their story, it's okay. There was another example I could give quickly on our IPC intervention where we worked with counseling centers, where a student had started the therapy by saying, I had a sexual assault, but I don't want to talk about it or tell anyone. And so we weren't even sure if it was right in our working, because we weren't working on PTSD as much as working with depression. But we worked with her, and what we found was really interesting was more and more we helped her see how disconnected she was from her loved ones and new people she was meeting, because she wouldn't tell anyone the way she wasn't telling us. So don't tell us, that's okay, but who are you telling? Or how would you tell them? Or how could you start to tell them? Because look how alone you are in keeping this to yourself. So as much as not maybe recounting it the way you were in prolonged exposure, I don't think we need to avoid it completely either. But we want to just keep staying with the principles of IPT, because that's what makes people, in the end, more resilient. Does that answer your question?
Yep.
Alexandra, I have a comment about that.
Sure.
So I think that if this isn't research and it's just like for clinical use, going with IPT, when you have a role transition, you start with kind of looking at the role that we gave up. Or when you have grief, you start by looking at, that's even easier to look at. You start by looking at the situation, the death, and whatever led to that, and, talking about, it's a traumatic event, and talking about what happened around that. And I think that with trauma as well, if you don't go by the research protocol, you can actually start by recollection of the memories, the traumatic memories. And this would definitely go with the regular IPT protocol, where the first part of the second stage would be like going back and talking about the change, the transition, the grief, so recollection of the memories around the traumatic event. And I feel like when I work in this way, it really helps people in the second part of the second stage talk to their loved ones and to the people on their circles about the trauma, because they did some emotional processing in the session. That kind of is much easier to now talk to, whatever you felt with your partner or with your family.
No, those are great points. I mean, obviously, if you identify grief as the problem area, you're going to do that grief work. If you look at the case examples in the IPT for group that Lena Verdelli developed, you'll see that a lot of that kind of sharing of the memories, allowing for memorializing of the person, are incredibly important. And, if I were to think of ways in which I might help someone be in touch with those ways of remembering or remembering with others, I wouldn't think I need to stop. It's just sort of, where is the focus? Is the centerpiece the trauma itself, or do you learn as much as you can about the trauma and then just help them be a functioning individual with that trauma as part of them, but not all of them? So like with this case example that I'll share tonight, this was someone who had multiple traumas, who talked about himself as a PTSD person, not even a person with PTSD. And the account of the traumatic experiences almost became robotic. You can tell them again and again, and they don't mean anything anymore. You want to help make meaning of them, absolutely. If we're thinking right now of all that we're hearing, I mean, it's still very acute. It's just raw. They've just happened, or they're happening. That's not even PTSD. So I don't see this approach as excluding exposure as much as thinking alternatively, how does one work if they aren't ready to do the exposure, or if they tried and it's too forceful and it's daunting and it makes them remove themselves from getting help, which has happened. So, but I think with all of these approaches that, just to step aside from the talk tonight, with all these approaches that we're learning and all these webinars, it seems like if we all come to a happy medium and figure out what we can draw from them and obviously apply to each individual, it's our best bet for sure. And IPT for PTSD initially was done in a group setting. So clearly there's a way in which people are going to share that traumatic experience, but as much they're trying to share ways in which people are getting back into their interpersonal functioning lives. And that becomes more the, let's say, centerpiece. So I'll tell you a little bit about this case example, and then I'll send it to Sharon to send out, because it's a written study that you can look at more specifically. And I think if you're like me, I learned so much more about protocols by reading case examples than just reading the manual itself. So you can read the manual. I hope this case example, which if you read it from beginning to end, it really walks you through the assessment piece, each phase, the techniques that are used, the outcome. So it'll help you if you're really thinking to use the approach in full with someone specifically. This is a case study.
This case is also on the IPT school website. You can find.
Oh, good. Okay, great. So you have it already. Great. So I'll take like 20 minutes to just walk you through, but there's more detail if you want. The privilege of me presenting this case, and now many years later, is that this was an individual who gave me permission to write his story. And we read it together, and he allowed it to be published. He was very proud of his story, but also the work that we had done. And we sometimes are cautious in the way we write case examples or give case examples. This is de-identified. You wouldn't, if you ever met him, you wouldn't necessarily connect this to him. But with his permission, I was able to really go into a lot more detail about what we actually did in the therapy itself. So this was somebody who did come after 9/11, a middle-aged male software engineer who had this multiple history of PTSD. He had described from a very young age being bullied. He had described a period of being separated from his mother when she was ill and away from him in a hospital for a long time. And he remembered that as really being something that affected his attachment in many ways to others throughout life. He had described being, I think, in or near a tornado. So he had like, here's a trauma, here's a trauma, here's a trauma. There have been many. But as I mentioned before, often when someone has multiple traumas, there'll be one that they call the trauma. And for him, the trauma was when he had been married, separated, they'd had a child. And when the child was around the age that he was when he'd been separated from his mother, so very young, like, 2s, 3s, 4, he was separated from her. So the story he told that was really the traumatic event was that as the couple had separated, he would have custody some weekends of his daughter. And when he went one weekend to take her for his turn to be with her for a weekend, he arrived at the apartment where his ex-wife was living with the daughter, and it was empty. They were gone. And he had no idea what happened. And this is sort of a triggering word for us all now, but he thought the daughter had been abducted. He was not even as concerned about his ex-wife as he was his daughter, because he described that as the one strong relationship he'd ever had in his life that was just unconditional. Over time, he discovered that the ex-wife had left the country with his daughter. He went on a mission to the other country to try to reconnect them. When he came to the treatment with me, the daughter was already in her, this decades later from the actual experience. And over that time, he had been to many therapies. He had been to a psychodynamic therapy. He had done some exposure. He was reading every self-help book he could find on the shelf. And even with all the therapies, decades after the event that happened that he called the traumatic experience of his life, he had created, literally in his words, a cocoon in which he lived, where he didn't leave the house. He found a way to work as a software engineer from home. Long before COVID days, he figured out how to do it all by phone and computer. He had a girlfriend who he sometimes called fiance, sometimes girlfriend, kind of showing the ambivalence he had of their relationship. And he said if it hadn't been for 9/11, they probably wouldn't even be together. There is a lot of talk back then, maybe there will be here too now, of how people's lives changed sort of profoundly after these horrific events. So he thought that sort of brought them together, but he was always sort of ambivalent about the relationship. But he literally didn't leave his house. When he was in therapy with me, the time he left his house was to come for the treatment, and that was it. And why did he need this cocoon? Because he had a high level of irritability, sleep disturbance, conflicts. He would get into arguments. If his girlfriend walked into the room unannounced, he would immediately kind of erupt and explode and get angry at her. And he was using cannabis daily just to manage his own feelings. So he was pretty avoidant of anything, any interactions with intense feelings. And then on top of that, there were these kind of current life stressors that he was experiencing. Again, thinking of IPT versus exposure. Do we expose him to the abduction that happened that weekend 20 years ago? or do we look at the current life stressors? Again, people with PTSD often have multiple experiences and many years of pretty chronic symptoms. So he had these strained relationships that really bothered him. Even with his daughter in her early 20s, he still felt like they weren't getting along very well. He was struggling with a business partner, struggling in his work, in his working relationship, struggling with his relationship, not just with his girlfriend/fiance, but with their family. And this was where assessing the interpersonal world, such as the trauma, he started surfacing some changes he was having in his sexual orientation, which wouldn't have, and his words didn't come up in previous therapies. So in terms of adapting IPT for PTSD, I'll just say a few words of what happened there. In hearing about the traumatic events, there was time at the start, in the initial phase, to hear about all of them. And there was time to understand which one was the most traumatic for him, even though it was a very long time ago. And it was time to start understanding his kind of emotional barometer. So by middle phase, when he would come in with experiences that were happening in the here and now, we could refer back to the emotional signposts. We could refer back to ways in which he was avoiding or numbing. I'll give you one quick example, and there are others if you read the case study, where he was trying very hard to repair his relationship with his daughter, who was a young adult by that time. They were doing better. And he described one day when I asked, how have you been since we last met? He said, I had this argument with my daughter on the phone, and I don't even know what happened or how it started. All I know is she hung up on me. So I asked, well, let's do a communication analysis. What did she say? What happened? And so he described a conversation, very brief, where she said, Dad, I have great news. I wanted to share it with you. I'm really excited. I finally decided what I'd like to study next. I'd like to study law. I'd like to be a lawyer. And his response was, oh, that's wonderful. So maybe now would be the time for me to share with you all that I went through during the custody battle with your mother. And then she hung up the phone. Now, we could go back to the event that happened 20 years ago, or we could understand what happened in that discussion. How are you feeling now as you're telling us that? How were you feeling when she hung up the phone? Let's do some perspective taking and understand what was going on for her and why she might have hung up the phone. There were a lot of examples during that therapy of ways in which he wouldn't be in relationship with others as much as try to teach them, as much as try to explain to them, as much as try to intellectualize things that were happening. That wasn't what she wanted to hear. She just wanted her dad. So with some communication analysis, with a little role play about maybe how to have the next conversation better or differently, we were focusing on him strengthening his relationship with his daughter, not as much on what happened 20 years ago, as much as let's get you out of that cocoon. So by the end, the self-exposures did occur. Just looking at pre-treatment versus post, again, we're not going to necessarily cure a person 100%. But what happened with this case and what happened with others on that studies since, is that just in strengthening interpersonal functioning, mobilizing social support, helping them find ways to feel their feelings, the PTSD symptoms can reduce without you focusing on the trauma. So where he came in, literally leaving his cocoon for one event of the week with frequent intrusive thoughts, dreams, bad dreams about the past traumas, even though they were a long time ago, avoiding anything that reminded him of those events, having a lot of discomfort in his relationship, intimate with his girlfriend/fiance. They weren't even intimate at the time, at the start of the treatment. Using cannabis, just numbing himself however possible to deal with the fact he wasn't sleeping well, deal with the anger and irritability. Really couldn't manage himself in the New York City environment, on the subway, on the street. After a time-limited approach of initial phase, middle phase termination, post-traumatic symptoms were someone who was just functioning better. If you skip down to the bottom, you'll see he actually didn't meet the criteria anymore for PTSD. Yeah, he had some intrusive thoughts, but they were less frequent. They were less intensive. He was able to tolerate social events. I remember he came in saying once, I went to a party last weekend. That, to him, was huge. Had become more affectionate towards his girlfriend. This whole questioning of his sexual identity, he started talking with her about, and that made a difference in them feeling close together. Talking about the bullying, that realizing that some of the bullying had to do with him having been somewhat effeminate when he was younger in an environment where he had to be very much a male. All of those, once shared with the girlfriend, made them actually closer, didn't make him break up with her to have a relationship with someone else. Started sleeping a little better, having less conflicts. In fact, the outcome of the therapy, he wanted to continue. It was very hard for him to end. I certainly enjoyed working with him too, but we thought, what next? And what we thought next to do was actually couples therapy for them, to start working on their relationship and seeing how they might want to strengthen it. That would be a next level, a next treatment. So he was able to go out in public a little bit more, the symptoms reduced without doing more than a trauma history at the start. So this, again, can be a way to learn the manual, I think, best through a case example. And I'll just then share as conclusion, what we know is that IPT can be an alternative treatment for chronic PTSD patients, especially if there's comorbidity. What we also know, if you're training and working with cases, and this is where through Sharon's school, I would encourage you learn the manual and then you take patients and you get supervision. The best we learn is through the patients we work with and through the ongoing supervision, because in John's words, you need a lot of poise to work with such chronic illness. You have to provide hope. You have to find help and hope for them and with them for improvement. And there can sometimes be advantages to not focusing on the trauma. Again, we don't have to, like a Bible, say it's forbidden, but we want to just keep them in the here and now and keep them on the strengthening of the impersonal functioning. And we could even think towards some of these core components in working towards resilience. How does one help to be a healthier functioning person, especially if they haven't been for so long? So the interpersonal inventory that we all know, that we all use no matter what adaptation, helps the patient explore the problem outside of the PTSD symptoms that might be affecting their functioning. So in Mr. A's case, interpersonal dispute ongoing, a little with the girlfriend / fiance, with the daughter as well, with the business partner. But then there's also a question about his own kind of a sexual identity. If we were to just take a trauma history and stay with the trauma history and work almost 100% on the exposure of the trauma history, we might miss something. We might miss something important in what could help them be a healthy adult, a functioning individual. So PTSD symptoms can actually diminish through the process of addressing these interpersonal problem areas mostly. And so I'm not the expert and I'm not a researcher, but if we think about how IPT might work, if we think of those mechanisms of change, if not exposure, then what? I think we just think about the strength of IPT. We think about this affective reattunement, that if anything, we're exposing one to their own feelings, not to the event itself, letting them feel their feelings without being terrified of them. And we're helping them somehow to using their emotions to kind of reassert control over the environment, using I feel statements, connecting the interpersonal experience to the mood or the symptoms. And that, in fact, can start repairing some attachment, whether it was, in my case's example, some anxious attachment from a very young age to perhaps a lack of trust or safety in attachment because of the traumatic experience. We've certainly heard that from all the sexual assaults we're learning about. That kind of attachment repair can sometimes make the difference, again, without focusing 100% on the symptoms. The traumatic event. So this is where I was planning to stop Sharon and say by next week, we're going to do some practices for those in the school who want to really learn. We're going to do and then feel. And then if people have questions beyond what we have some time to answer now, again, maybe they can write them in and I can collect those so I can think even how to come in specifically with a role play based on something somebody has been working on in a therapy they're doing, or a burning question they have about a therapy that they might be doing. So that's it. I'm going to stop the slides now and see if anyone's still awake. Questions?
Thank you very much, Alexandra. And I do want to say that if any of you, מישהו רוצה לשאול שאלה בעברית, אז אפשר לשאול גם בעברית, ואלכסנדרה מבינה גם עברית, כן, היא תענה באנגלית, אז אתם בהחלט מוזמנות, אני רואה שכולם כאן בנות, בהחלט מוזמנות לשאול בעברית.
אני אשאל אם אף אחד לא שואל. I feel like I have tons of questions for you, Alexandra, since it's so relative now in the sense of what we're going through. A question about the skills base. As you know, IPTA is very, very skills based, especially in the middle phase. And when I hear you, and I also heard John talk about it, it sounds much less so, besides the skills of how to deal with severe emotions and, the practical side of communicating what you feel with the I statements, etc. But I was trying to hear and kind of peek your skills out of the, emotional and interpersonal. And I was curious how you see it especially in the middle phase.
Yeah, that's a really good question. I mean, I think some of it is John's style. I mean, he doesn't work as much with, he doesn't do the circles. He doesn't work with homework. And the way he was trained himself and with Klarman was that it was much more just the two people in the room and making suggestions as it was, here's a worksheet or here are skills. But with that said, I think specifically, again, if we're thinking post-traumatic stress disorder, this very small percentage of a population, we're thinking of people who are very avoidant, and it's not that easy to do skills unless they've really managed their way in and have bought in. So this case example, what else would I do with him besides really hear what happened in that phone conversation, do a good communication analysis, and just try to encourage him how else he might talk to her, to try it and let me know how it comes back, rather than give too many skills that he might become sort of daunted by or avoidant of. You don't want them to feel sort of hopeless and that's too much for me to do, that's impossible for me to do, as much as you want to just kind of give them a sense of you can do, try this, try one thing. But with that said, I think with all of these, I see a lot of, again, familiar faces here with all of us who do IPT. We know that whatever we know of IPT, it's not going to be exactly the same from one person to the next. If I'm working with an adolescent who's had a traumatic event, I might very much do, here are the communication skills, let's practice it together. How would you do it? Let's practice some I feel statements. Let's actually write on a piece of paper all the different emotions. Which one are you feeling? Let's do a mood monitor every time. I think I would kind of gauge that based on the person, how much structure they may need, based on the age, which with the emerging adulthood group, I often feel they don't need as much skills and they don't want them. They want to kind of decide for themselves because they're, becoming more mature adults and they're working on that part. So his manual itself just gives, the guidance of here's how you do a role play. Here are the components of communication analysis. I think there's also now some IPTA for PTSD, right? So I imagine they've probably built more skills into that middle phase in the newer manuals. I just basically think we have to think of people who are numb to their feelings and avoid it. So as much as you can try through doing, but what happened and how did you feel about that and how are you feeling, as much as let's practice this exercise, let's practice it again, because you really want to get somehow them a little bit more in touch with the feeling part. And the skills sometimes can take away from that, although I'm not against them. Any other questions or Charlotte? Maybe I'll just take a minute to share. After John came and did the webinar for, it was a Gaya Hospital and Reichman University, we invited him to join us at Ben Gurion University for a smaller group. We put together a group of about 25 volunteers. There are 3 clinics at the university. There's the Sharut, where I'm the director, and then there are 2 other research clinics on campus. And because the university has been so affected, with many people lost, with many of our own on Miluim or not able to work, we sort of pooled together the 3 clinics and created a group of volunteer clinicians to be sort of on call. So we have sort of a kavham that's still functioning, that takes in calls just specifically for the community. So I gather them all together to just meet John for an hour and tell him their experiences of what it's like to take these calls from someone who was at the Nova party, from someone who's still waiting and hearing whether a friend of theirs is still alive or not. And he was pretty humbled and said, I don't know, and we don't know as researchers as much of what you do during trauma as what you do after. So he really was like, I want to hear more, and I want to share with you maybe ways to think of IPT towards building resilience, if anything else, because the rest is later. So, I mean, if there are no questions, I'll just share that it's not that this is the answer as much as it's something else for us to be thinking about in our repertoire.
So, Alexandra, when we think of PTSD, we think of maybe 3 months after the trauma or 6 months after the trauma. When do you
or 20 years? No, really.
When how close to the trauma would you start using this protocol?
I mean, there's, by definition now, there's a difference between acute stress disorder, post-traumatic stress disorder. By definition, it can be a month after. Someone can still be just acutely experiencing something, and you wouldn't automatically label them as post-traumatic stress disorder. In my world currently, where I hear post-traumatic stress disorder used most as a diagnosis is students who've already been through the army, experienced traumatic events, and are hoping with the diagnosis they might get services, they might get support. It becomes a diagnosis the way a learning disability becomes a diagnosis that might help someone with services. And that's where you get into the, is it PTSD or not? Because the Army doesn't always want to give everyone the PTSD, right? And it's just actually pretty extensive how one has to go through acquiring that diagnosis. But personally, I think that definition between acute or post, I mean, when we think of how we're starting and how we're working with people currently, back to that webinar, Sharon, that you shared with us, similar to when someone has been assaulted sexually, we would never question the validity of what they're telling us, right? If you're coming to tell us about an event that happened to you that was horrific, that was traumatic, I want to hear about it. We don't want to know right away, is it PTSD or not? Certainly they don't either. We want to just give them the chance to talk because it may have taken years for them to get to that point. Yesterday, somebody I was supervising from our Kavham told me, I'm trying to remember the story, that she was near the Otaf. She had been shot at on the day. And in talking to one of our clinicians yesterday, so that's now 6 weeks, it was the first person she had told. So would we at that moment say, oh, is that a traumatic experience or not? Is it 4 weeks? Is it 6 weeks? We would listen. It's the first person she told. So let's let her tell that story first, and then let's decide what happens next, and let's assess how many symptoms she's having. And she was having enough that were turning into nightmares, startle responses. And then we think gradually how we might work with her. And I don't know if that would always be IPT, but certainly I like always think of IPT as the alternative for if they're not ready to do the exposure work. Or if in that case, why haven't you told anyone? Who have you been with for the last 6 weeks? What's going on in your life right now? Where are you living? That might immediately lead more into, I think, the IPT work we all know and love, right?
Another question, Sandra. So right now it seems like everyone is emotionally affected, and it's really hard to kind of expect how someone will respond because they don't respond the way we're used to them responding. And that makes IPT a little more difficult. Like when you do role play and you could play your partner because you know how they usually respond, but right now they're not responding like they do usually. So I think that, in this case, when everyone is, everyone has gone through some sort of trauma and everyone is affected emotionally, it really changes, all sides of social exchanges. So your friends are different and your partner is different and your children are a little different, and it makes things much more difficult. So I'm wondering maybe if Alexandra or anyone else who's encountered this, what do you think about it and how do you work with it?
That's a really important question. Does anyone want to share? I mean, I think we have to all just maybe come to terms with the fact that we are all different and we won't be the same. And so what does that mean in our relationships? Will that make them stronger? Will that end some relationships? Maybe. I certainly know, just forget therapy, just in my own life and professional life, I feel that I have no tolerance to work with anybody if there's too much conflict or if we're not somehow kind of working together. And, and there are ways to work through conflict, but there's also this, I don't know if I'm describing it right, but the feeling different is, with the time we have now, with all that we've been through, what can we do that's purposeful? What can we do that's meaningful? Like, there's less tolerance for what's not. So that might bring people closer together, or it might bring people further apart. And I think that's part of what we've changed. I mean, how do you go back? How do we go back to who we were?
אני אוסיף רק בעברית, כי זה יותר מהר ויותר קל לי בשעה הזאת. שאני חושבת שטוב, היי. אני חושבת שגם במהלך השיחה, כמו שאלכסנדרה תיארה במהלך גם התיאור מקרה וגם בכלל, אז אני חושבת שביחס למה ששרון שאלת, שאנחנו מרגישים שונה ואנחנו אחרים באמת, אבל בתוך השיחה מוצאים גם את האורגנים המוכרים. זאת אומרת, גם איך הייתי, מה עזר לי, בטח בהקשר הבין אישי. זה כן מעלה לי איזושהי שיחה שהייתה לי כשליוויתי משפחה מהעוטף, והיו קשיים בין בני הזוג, שגם הקשיים הם לא חדשים, אבל סביב האינטנסיביות והטראומה שהם עברו, באמת היה קושי מאוד מאוד ניכר בתקשורת ביניהם. ובכל זאת, בתוך השיח הזה הצלחנו, עבדתי עם האישה, אבל הצלחנו איתה, היא הצליחה להתחבר לדברים שכן היא מכירה בעצמה. זאת אומרת, נכון, עכשיו זה קצת שונה, והיא מאוד מוצפת, והיא מאוד מגיבה מהר, קשה, אבל היא כן הצליחה להתחבר גם אם זה קצת לדברים שהיו מקודם. ואני מרגישה שזה משהו שכן עוזר, כאילו להתגבר גם על השונות, כאילו על הטראומה, כאילו, כמו שאת אומרת, אנחנו אחרים וחווינו יותר מפחות, מאיפה, מקרוב, מרחוק, כל הדבר הזה הוא באמת מאוד מאוד מורכב, ואנחנו באים לזה אחרת, אבל יחד עם זה אנחנו מביאים איתנו גם את מי שאנחנו.
נכון. That's beautifully put. Yeah, absolutely. Yeah. When we talk about in IBT with role transition, you know, you're more in the loss of the old and you accept the new and you learn to adapt to the new role. That doesn't mean we can't still draw from the old role, what was important or who we were. What do we want still to be? You know, who do we want still to be today, even after all that's happened? It's important to remember.
מיוט, אוקיי. אני אומרת לסיכום, אנחנו באמת בתקופה מאוד 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 מאתגרת, ובטח גם מאוד מאתגרת עבור IPT, וכמו שאמרת, אלכסנדרה, הולכים להיות שינויים מרחיקי לכת באנשים, במי אנחנו כקהילה, ומי אנחנו כחברה, ואנחנו עוד לא יודעים כל כך לאן הדברים הולכים, אבל אני כמעט בטוחה שה-IPT ביכולות שלו ככה להתחבר למקומות הכי בסיסיים שאנחנו זקוקים להם, של הקשרים, ולהתחבר בחזרה לרגשות שלנו, ולהיות מסוגלים לתקשר את הרגשות שלנו עם אחרים. אני חושבת שזה פשוט יהפוך דברים ליותר קלים, עבור האנשים שיהיה להם מגע עם ה-IPT. זאת אומרת, אם אתן בוחרות לטפל ב-IPT, אני חושבת שזה יעזור בסופו של דבר לאנשים לחזור קצת יותר לדברים המוכרים, לדברים שנותנים לנו ביטחון בחיים, שזה האנשים הקרובים אלינו. אז אני מקווה שנוכל לשנות את העולם באמצעות IPT, לא, אבל אולי קצת בקטנה לפחות את המעגל הקרוב אלינו. וכמובן תשתמשו בזה גם בעצמכם, כי זה ממש נראה לי דבר ראשון, שאנחנו נהיה במצב שאנחנו יכולות לטפל.
אמן.
סנדרה, תודה רבה.
תודה לכולם.
אמן.
כולן, דבר.
ביי, לילה טוב.
לילה טוב.
ביי, לילה טוב.
טוב.